Good evening, everybody. Welcome to this session, and thank you for your attendance and interest. So today the session will be about inotropes and vasopressors, which went too big. I would like to introduce Dr. Ahmed Al-Farsi, who is a pediatric intensivist at Rustak Hospital. Dr. Ahmed Al-Farsi finished his medical school at Sultan Qaboos University. Then he finished his residency, pediatric residency program in Oman Pediatric Specialty Board. Then he went to Canada to do PICU fellowship at McMaster University, during which, beside his clinical work and experience, also he was the chief fellow of PICU program at McMaster. And also during that time, he did research projects and also participated in quality improvement project. So currently he is at Rustak Hospital, PICU, and also he is the head of quality improvement or quality and safety department at Rustak. Dr. Ahmed is interested in quality improvement mainly, and we know him that he is always active and always trying to improve the service that is provided for the patient. So welcome, Dr. Ahmed.
Thank you, Dr. Saif, for this nice introduction.
Yeah. So we know the title. So what you are going to talk about today?
Good. So thank you, Dr. Saif, for this introduction, and thank you for the attendance who are participating with us to share some of the informations, discussions around a very important topic about inotropes and vasopressors. So today, my plan or my objectives for today's discussion is to provide the audience with an understanding for the basics of arterial oxygen delivery. So maybe it simplify all what we are doing around the inotropes. It's to improve arterial oxygen delivery. So I will explain this concept clearly. Then the main discussion or the main bulk of today's discussion, it will be physiology-based discussion around the action of inotropes, their receptors, where they are acting, and what actions you will anticipate by adding an inotropes from different classes. So today it will be mainly basics of the today topic, which mainly will be physiology-based discussion. And again, at the end of this presentation, I hope all the audience, they will have a new approach on how to select, because usually that will be discussion whenever there is an opportunity to start an inotropes or vasopressors, which one we should choose. And that discussion will be based on what evidence we have to choose a new or our target inotropes or pressors. So my today discussion would be around those points.
Thank you, Dr. Ahmed. So I would like also to invite all attendees to also participate in this critical care discussion. It is meant to be a discussion. So feel free to talk or ask or interrupt, either by unmuting yourself, or also you can put your questions in the chat as well, and we will go through them. So it is better, and I think it will be more practical to start with a case, clinical case scenario, to make this session not only a theory, but we want it also to be practical. So in case we have a similar patient, we know how to manage such a patient. So probably I will go with a case scenario. We will read it together. Then we will ask Dr. Ahmed how to manage such a patient. So if we have a 5-year-old child with ALL, acute lymphoblastic leukemia, last chemotherapy was given 1 week back, presented with high-grade fever, poor oral intake, cough, and respiratory distress. On examination, the patient was cold. His pulses were weak. Capillary refill times was 5 seconds. He was confused and very lethargic. He was tachycardic, heart rate was 200. His blood pressure was 110 over 65. And he was tachypneic as well, and the temperature was 35. His saturation was 90% on non-rebreather mask. And the systemic examination showed bilateral lung crepitation. This patient was managed with fluid. Then till a point that the team start to think about starting inotropes. So in such a scenario, Dr. Ahmed, if you can elaborate how to manage such big sick patient who is very tachycardic and is poorly perfused. The question that always come in mind, what inotrope I should start for this patient, and which inotrope is the most appropriate that may improve the hemodynamic of this patient.
Good, excellent. So I think the scenario which you have mentioned, it is one of the common scenarios for a child who is known to have malignancy and underwent chemotherapy. And those kind of patients, they are prone for catching an infection and coming to hospital with picture similar to septic shock. So before going ahead with answering this question, because this will be the target or the aim of today's discussion, I would like to start the discussion by mentioning some concepts, definitions, so it will make the answer or the clarification around what type of inotropes or pressor to be picked for these patients easier to be understood and easier to be followed. So before we start, let's discuss about some concepts, which I think they are an important concept for people to understand what inotropes to choose based on the pathophysiology. So usually inotropes, we started if we have a child on shock, regardless on the type of shock. So what is shock as a definition? So it is a life-threatening condition, and put 100 lines below a life-threatening condition of a circulatory failure, which lead to inadequate oxygen delivery. So this circulatory failure will lead to inadequate delivery of oxygen to the cells to meet cellular metabolic needs and oxygen consumptions, which ultimately will lead to tissue hypoxia, multi-organ dysfunction, and unfortunately to death. So shock is an emergency. It is a status where it can threaten the life of the child. And the main issue with shock is there is inadequate oxygen delivery. So in simple, whatever interventions you will provide to your patients, whatever inotropes you will start, your goal is to maintain adequate oxygen delivery to the cell to prevent the sequelae of tissue hypoxia and multi-organ failure. So this is a very important concept, need to be clear before we start. Then one of an important concepts too, and usually you will face it at bedside, a child who is in shock, but the blood pressure is normal. Is the child is not in shock? There is no shock in terms of inadequacy of oxygen delivery to the cell or not. So to make things simple, patient in shock can present hypotensive most of the time, or normotensive, or hypertensive. So yes, a child with a normal blood pressure or with a high blood pressure can be in shock too. And during my subsequent slides, you will understand how it comes that the child in shock, but his blood pressure within normal range. So as we said, arterial oxygen delivery will be our main bulk of discussion today, because that's what will end up in tissue hypoxia and the end organ dysfunction. So let's take things step by step. I don't know if if we will have a chance for the audience to participate, but let's start with that, and we will see. So arterial oxygen delivery equals to cardiac output multiplied by arterial oxygen content. So again, for anyone working in ICU status, this slide is considered one of the initial and one of the basics slides, and one of the important slides need to be clear, because you will apply it daily, consciously or unconsciously. So you need to be familiar with those concepts. So arterial oxygen delivery equal to cardiac output multiplied by arterial oxygen content. So maybe I will open the stage for the audience. Cardiac output, it equals to what, or it depend on what? Based on your previous information and your practice in ICU. You can answer in the chats, or you can unmute yourself and answer.
Ghaida Al-Mzeni, she wrote in the chat, it is heart rate multiplied by stroke volume.
Excellent, good, so that's correct. So cardiac output equal to heart rate multiplied by systemic vascular resistance. And the second factors influence the arterial oxygen delivery is arterial oxygen content. So just bear with me. Arterial oxygen contents is depend on hemoglobin, saturation, and dissolved oxygen in the plasma. So, and the equations, as you see here, down it is 1.34, and I will ask the audience again, because that will figure out those who are reading in ICU topics. 1.34, it reflects what? It's constant of what? In the equation of arterial oxygen content. Anybody has any idea? Okay, so 1.34, because again, for me, I believe we need to understand better than, or we need to understand the figures and what the meaning of them more than just memorizing them. So 1.34, it is the amount of oxygen which bound to 1 gram of hemoglobin. So, and here up you can see it is the quantity of oxygen bounded to hemoglobin. Okay, so the amount of oxygen bounded to 1 gram of hemoglobin. Then saturation, so that's what you will get in pulse oximetry, plus 0.003, which is a very minute amount, but it is part of the equation. So again, 0.003, it is the amount of oxygen dissolved in the plasma. So far, we have so many factors influence arterial oxygen delivery. We started with cardiac output, which is heart rate multiplied by systemic vascular resistance. Then arterial oxygen content, which depend on hemoglobin, saturation, and dissolved oxygen. So from whatever you know that to improve arterial oxygen delivery, improve cardiac output, then we will elaborate more on it, and improve oxygen content. So that means by optimizing hemoglobin, by improving saturation, by changing your amount of respiratory support, amount of mechanical ventilation, and so on. Okay, so heart rate, we'll go back to cardiac output, heart rate multiplied by stroke volume. So heart rate is the amount or the number of beats per minute, and stroke volume. Again, one of other classical questions, stroke volume, it depends on what? I think all the audience should be able to answer this question.
Ahmed in chat wrote cardiac output, preload, afterload, and contractility.
Okay, good. Thank you, Ahmed. So yes, this is what stroke volume depend on. But cardiac output, there are two players helping or affecting the cardiac output, what you have mentioned, plus the heart rate. So stroke volume, and now he's writing the right answer, stroke volume depend on three factors, which are contractility, contractility and afterload. And preload depend on the amount of fluid or the fluid status or volume status of the child. And again, we will have some elaboration around it. Contractility, how strong the heart is contracting against the resistance of the vessels. And and afterload will be the resistance of the vascular beds. So as you see, there is so many factors influencing the arterial oxygen delivery. And by understanding those factors, it will help you finally at the end of this presentation to decide which one I need to improve. So I will improve arterial oxygen delivery. I think you have noticed whatever I have discussed, there is no mentioning about blood pressure. And usually when we are in a real clinical scenario, we will have a child who is in shock. Everybody will be pointing to the blood pressure. If blood pressure is low, means we are so late. We need to resuscitate this child very fast. We need to give fluid, start inotropes. But as whatever we saw so far, there is no mention about blood pressure. So any idea what is the factors influencing the blood pressure from your previous information, previous knowledge? Anybody can guess? Good, excellent.
Someone said, my phone, cardiac output.
Good, so cardiac output, one of the players, and I believe Naji, he wrote before iPhone that it depends on cardiac output and systemic vascular resistance. So that's true. Blood pressure directly related to the cardiac output, the better cardiac output, the higher the blood pressure, and systemic vascular resistance. So let's go back to what I have said before. Shocky child does not require, or it's not necessarily to be hypotensive. And a hypertensive child, maybe he is shocky. He is in a very shock status. Let's put an example. A child who came with septic shock, he has very high systemic vascular resistance. So the blood pressure will be high, even if there was little bit increase in cardiac output or cardiac output was same, systemic vascular resistance was high, then the blood pressure will be high. But in this scenario, in these conditions, if there is no change in cardiac output, maybe there will be deficiency or there will be an effect on the end organ perfusion. So the bottom line, blood pressure will not stand alone for you to give a justification about the end organ perfusion. So put blood pressure with other factors. Now, what will be other factors to be considered beside or with blood pressure to comment on end organ perfusion? How good we are perfusing the organs? What other parameters we should depend on? So we can put things together in this slide. Any comments, any answer? Other than blood pressure to help you guide, good, excellent. So I can see some answers in the chats. Lactate, good. So if there is high lactate, even if you have blood pressure, then there is a problem. Most likely the child is not getting well perfused. Excellent, good. Urine output, it is one of the excellent indicator for the end organ function. If there is less urine output, means there is less renal perfusion. That means there is an impairment in oxygen delivery to the kidney. Capillary fill time, excellent to the skin. Then other important factor or important evidence like mixed venous saturation, again, it will give you a clue. Thank you, Abdul Hamid Al-Hinai. Mixed venous saturation, it will give you a clue. So all those, excellent, all what you have mentioned, which it gives you a clue about the end organ perfusion. It needs to be put with blood pressure. So the bottom line, normal blood pressure with clinical and biochemical evidence of end organ perfusion impairment, it does not stand alone. Means you need to improve end organ perfusion by adding inotropes, giving more fluid, and do some changes. And again, we will discuss in the subsequent slides what other changes you can do. Okay, I think this is, just go ahead, Dr. Saif.
Thank you, Ahmed. So what I can see in the chat, there are very excellent answers that indicate that the cardiac output, I mean, when we want to judge clinically bedside, the cardiac output is not dependent on one number only. It is not independent. It is not dependent on heart rate only, on the blood pressure only. And usually we don't act, we don't interfere with the patient, we don't give intervention depending on one number. And as mentioned in the chat, there are multiple indicators, there are multiple clinical examination findings that will tell us about the cardiac output. And I can see in the chat some mention about heart rate, lactate, urine output, peripheral pulses, the mixed venous saturation, the conscious and alertness of the patient, and also the peripheral perfusion as well. And so this, Ahmed, you talk in this slide, actually, you talk about a very important concept that really we need to understand, and it will help us to understand how to manage the patient and how to evaluate the patient. And maybe I will ask you multiple questions. We always, when we read about hemodynamic and we read about inotropes, we come across different terminology that include inotropy, chronotropy. Sometimes also we talk and we say inotropes. Sometimes we say vasopressors. So before going to other topics and to explain about the action of those medications that we use to improve hemodynamic, can you talk slightly about those definitions, or what are the definitions between inotropy and chronotropy, and what is inotrope, what is vasopressor?
Good, excellent, Dr. Saif. So that's what I'm going to do in my next slide. So again, to have a common language when we practice or when we manage patients, that will make the life easier. So we can understand each other and we can discuss the management easier. So some definitions to consider. So usually you will hear, let's start inotropes, and let's start pressors. Sometime let's give a medication which it improves the heart rate. Then the other one will say, no, let's give a medication which improves contractility. I believe we may need to speak, we should speak in a common language. So let's have some definitions. As you see in this slide, inotropy is the force of muscle contraction. So it is inotropy equal contractility. So improving inotropy means you are improving the contractility. And usually the inotropes, they are put all together. Inotropes, vasopressor, inodilators, all put under the name of inotropes. But again, inotropes is the medications which improve muscle contractility only. So it will improve cardiac output by improved contractility. Chronotropy, or the chronotropic effect, means increasing the heart rate. So some inotropes, they have inotropy and chronotropy, and we will see which type of medications targeting which type of receptors to improve chronotropy. Then lositropy, so it is the medication which help in relaxation of cardiac muscles and chambers. Then vasopressors or pressors. So it is mainly the medication which cause vasoconstriction. So to make things easier, and again for you at bedside practice, when we say inotropy, then the medication which improve cardiac contractility, chronotropy, medication which increase the heart rate, pressors or vasopressors, the medication which cause vasoconstriction. Okay, good. So next in my discussion today, I will just go quick to just refresh your mind, because again, I think people, they are mentioning that stroke volume is preload, contractility, afterload, but the concept or what the factors influence the preload, afterload, and contractility is not almost always clear. So what is preload? So the preload, it's equal to the pressure or the stretch exerted on the wall of the LV, or it is the left ventricular end diastolic volume. So it is the volume, the amount of blood which is retained from venous system to the heart. And it follows Frank-Starling law. So what Frank-Starling law or curve? When you increase the ventricular end diastolic volume, like what you see here, there will be a direct increase. It's proportionate to the stroke volume. The more you give of fluid or blood, whatever, in terms of volumes, it will be followed by increase in stroke volume. So let's put our example. A child who presented with septic shock, you give, maybe he's at this stage, you give the first 20 ml per kg of fluid, you have increased the left ventricular end diastolic volume. So increase in left ventricular end diastolic volume will be followed by increase in stroke volume as per the Frank-Starling curve. You will do the same thing. You will give the second bolus. You will increase the left ventricular end diastolic volume. That will be followed by increase in the stroke volume. And that's why, because there will be stretching of the heart muscles, and that stretch in heart muscle increase the action potential and increase the force of contraction. But again, an important point here, that stretch, it is not infinite. There is a stage which you need to know where more fluid will lead to left ventricular dysfunction, because there will be overstretch of left ventricle. So preload is the amount of volume given to the patients, and it is measured by the amount of ventricular end diastolic volume. More volume, more stroke volume, more contractility, and that will continue till a stage where extra volume will lead to left ventricular dysfunction because of overstretch of the sarcomeres.
So that, Ahmed, can I interrupt you here? So yes, you mentioned that the preload is the amount of blood or volume that entering the left ventricle. What about the amount of blood that is coming to the right atrium and right ventricle? Because especially when we talk about cardiopulmonary interaction and about the effect of ventilation, also we say that the ventilation reduces the preload to the right ventricle, or the amount of blood that is coming from superior and inferior vena cava entering the right atrium. How that will affect, or can it affect also the cardiac output?
So you mean the mechanical ventilation?
No, I mean the preload to the right ventricle.
Good. So usually we speak about the right ventricle because it is the ventricle which receives the blood from the body. But most of the discussion that the amount of blood in RV, it will go to the lung and it will come back to the LV. So what is applied to right ventricle will be applied to left ventricle, because whenever we will speak about cardiac output, we are referring to left ventricular end diastolic, left ventricular systolic function. So it is the amount of fluid in both sides with the amount of volume will be similar. If that is your question and I got it correctly.
Yes, that's my question.
Okay, good. So our next point will be the afterload. So again, afterload, we mean it is, by it is the resistance to left ventricular contraction. And indirectly, and most of the, during the day-to-day practice, we refer to afterload by systemic, the amount of systemic vascular resistance. But again, afterload, and we'll see in the subsequent slides, it include both systemic vascular resistance, so it is the resistance of the peripheral vessels, and the resistance in the great big vessels like the aorta, which located intra-thoracic. So there is an extra layers which called transmural pressure. We may refer to it in the subsequent few slides. But in general, afterload, it mainly measured or referred to by the systemic vascular resistance. So high afterload will lead to increase in myocardial workload. So that means the heart muscles or the LV will need to exert a very high force to overcome this resistance. An increase in afterload will lead to decrease in cardiac output. The last one, but not least, is the contractility. So contractility is the ability of myocardial muscle to shorten or to contract forcefully independent of preload afterload. What does mean? So it means when you want to improve contractility, but you don't want to give the child fluid. The amount of fluid in the child or in the intravascular compartment is adequate. Or the level of afterload, regardless of that level, you want to increase the contractility so that you can do it selectively by using an inotropes. So as we discussed in preload, giving more fluid, improving preload will improve contractility. But sometimes you don't want to improve contractility based on Frank-Starling law, especially if you are at the edge where more fluid means the impaired left ventricular function. So at this stage, you need to think about a medication which help in improving contractility. So back to this chart, in diastolic volume, in the X line, cardiac output in the Y line. So decrease, improving in diastolic volume, as we said in Frank-Starling law, will lead to improve in stroke volume. Okay, so here is in normal contractility where you don't have any impairment or any issue with contractility. If you have a child who has, let's say, heart failure, at the same in diastolic volume, you will get less cardiac output, less stroke volume, because the myocytes are weak, they are unable to function normally. But if you give a medication like inotropes to improve the contractility, or in during exercise where there is strenuous exercises, the contractility of the muscles will be better at the same preload, the same intravascular compartment. So that will lead to independently to increase cardiac output. So far, we have discussed about preload, afterload, and contractility, and I hope you have understood them correctly, because what's coming next will be directly related to what I have discussed so far. Yes, sir.
Thank you, Ahmed. So that's mean of everything that you have said. When you have a patient who is hemodynamically unstable, who has signs of low perfusion or poor perfusion because of reduced cardiac output, we need to target mainly those three things: the preload, contractility, and also optimizing the afterload. So the preload by giving fluid and improve the intravascular volume. And for the contractility and also afterload, we need to start medication like inotropes or vasopressors. So it will be interested to know and understand how those medication work. And also if I start medication like, for example, adrenaline, what are my expectations in the patient to see in the patient? What the improvement that I can expect to happen?
Good, excellent. Good. So now we will tie whatever we have discussed, theoretical part, to more of inotropes and vasopressor related physiology. So to make things, let's have some schematic drawing to what we have actually in real life when we have patients. So when you have patients, you have a heart, which is the pump, which pumping the blood to the rest of the system. And this pump depends on the preload. as we have discussed, and it follows Frank-Starling mechanism, as we said before. So it's here for you to refer to. So how we can improve the contractility, because again, that's what we have discussed. It is preload, we talk about the volume. Contractility, how we can improve the contractility in the heart. So that can be done by targeting receptors. Sorry. So that's for the preload, we already discussed. Then afterload, let's finish the upper part. Afterload, which reflect, as we said, the LB contraction and the degree of constriction and dilatation of the arterial circulation. And again, afterload, it is include the resistance intrathoracically resistant at the aorta level and systemic vascular resistance. And usually we will measure the blood pressure before the end organ. So at the medium size arteries. And systemic vascular resistance, so it's the resistance of the arteries and arterioles. And all what we are doing is to improve the perfusion of the end organ. So for afterload, some factors you need to consider when you have sick patients. Afterload increased by hypothermia. If the child is cold, calmy, very poor perfused, and hypothermic, that will lead to an increase in afterload. So it's a factor which you need to improve by rewarming the child to improve or to decrease afterload. Increase in transmural pressure, and again, that will bring us to the mechanical ventilation. And without mechanical ventilation, so with mechanical ventilation, transmural pressure will decrease and afterload will be less. That means there will be less resistance for the heart to pump against. And I believe this will be one of our discussion in the near future. Then increase systemic vascular resistance. For SBR, there is two concepts to make your life easier if you understand them. First of all, there is direct relationship between the blood flow and the pressure gradient. So the higher the pressure gradients between 2 points, let's say this is 1 point and this one another point. If the pressure gradients between those 2 points is high, means there is a significant difference in the level of pressure, so the flow will be better. There will be more blood going to that organ. Let's take an example of traumatic brain injury where there is increase in ICP. If ICP increase, so there will be high pressure at this point, and you have mean arterial pressure on the other point. If ICP high, so the difference between the pressure between two areas will be less, then the blood flow will be less too. As we said, it is direct relationship to the difference in the pressure. Then the second concept, the relationship between blood flow and the resistance. So it's as simple as this. High resistance means there will be narrowing in the blood vessels, will lead to backflow of the blood, and the flow to that organ will be less because the radial will be less, the resistance will be high, well, that will lead to decrease in the blood flow. So blood flow is inversely related to the resistance. So that's the initial explanation about this schematic drawing. Let's take the receptors. So in the heart, we have beta-1 receptor to improve contractility and heart rate. Contractility, we said the inotropy. Heart rate, we said, is the chronotropy. Before, I have difficulty to put B1 in the heart and the other receptors B2 in the blood vessels. So if you have the same problem, all human beings has one heart. So beta-1 receptors is available or located in the heart only. So beta-1 receptor activating beta-1 will lead to improved contractility and heart rate. Then we have another receptors called alpha-1 receptors and B1 receptors. So those receptors, or vasopressin receptors, those two receptors are located in the peripheral vessels, and activating those receptors will lead to vasoconstriction. So there will be narrowing in the blood vessels if you activate those two receptors. Those activation of those receptors will lead to increase in systemic vascular resistance, will lead to increased resistance. So as we said, increased resistance will lead to a decrease in blood flow to those organs, okay? With that, you will have a higher mean arterial pressure. Who will benefit from this high mean arterial pressure? The other important organs like the brain and the heart, because the autoregulation there is better, and the body by itself will try to deviate or try to move the blood flow from less important organs, let's say, to more important organs. So activating alpha-1 and V1 receptors will lead to vasoconstriction, lead to increase in resistance, reduce in blood flow, and the reducing in blood flow to those organs will lead to increase in mean arterial pressures, mean the pressure will be, or the flow will be better for other vital organs like the brain and the heart. Again, using those medications or those medications who target those receptors will lead to impairment in perfusion of those less important organs, let's say, and that's what usually you will see at bedside. So we have talked about beta-1 receptors, it lead to or help in contractility and improving heart rate. We have talked about alpha receptors and V1 or vasopressin receptors, which work mainly on the peripheral vessels, causing increase in SVR. Then the last receptor will be beta-2. So beta-2 receptors, it's located in the peripheral vessels. It causes peripheral vasodilatation. So it will lead to dilatation of the blood vessels. Let's go back to our equations here, that the blood flow inversely related to resistance. When you dilate the blood vessels, the radius will be larger, bigger, then the resistance will drop. So by dilating the blood vessels, less resistance you will have, more blood will go. So you will get an hyperemic status, where there will be flush of blood going to the end organs. And that's what you see sometimes in your patient. The child is very sick, is very septic, but he's hyperemic. His cap refill is less than 2 seconds. So that's because of peripheral vasodilatation. And again, with this peripheral vasodilatation, because there will be gush or there will be an increase in the flow of the blood to these organs, that will lead to decrease in mean arterial pressure. And again, it has its own drawback if it's continued to be low. So, so far as we have discussed about those receptors, now we need to link those receptors with the medications. So maybe here I will stop, then I will ask the audience, what medications from inotropes and pressors target beta-1 receptors based on your previous information and practice. You can unmute yourself or write in the chat. Then we will move to the next slide. Good. So iPhone said adrenaline. Good. So adrenaline is one of the medications to work on beta-1 receptors. Any other answers? Okay. Team. Okay, still people mentioning adrenaline. Okay, good. So adrenaline is a good example. Noradrenaline, norepinephrine is another one. Dopamine, good. I can see some answers for dopamine, dobutamine too. Good, excellent. For alpha-1 receptors, you can write in the chat. So for alpha-1, you have norepinephrine, you have phenylephrine, if you used it before. And for V1 or V1A receptor, you have vasopressin. So it's one of the medication which activate V1 receptors. Beta-2 receptors, again, what you have mentioned before, epinephrine, Dopamine has some effect, dobutamine, and right. So those are the most common medication affecting beta-2 receptors. Okay, so just to make things easier for you to follow, this table explain all those inotropes and where they're acting. I will go through it fast because again it's difficult to memorize, but just for you to know. So norepinephrine, it is pressors, cause vasoconstriction. So based on our discussion, it mainly act on alpha-1 receptor. So it's alpha-1 agonist, it causes peripheral vasoconstriction. And it has some beta-1 activity for which it will cause increase in chronotropy and inotropy. So the net effect or the physiological effect, it will increase SVR because it acts on V1, alpha-1, plus minus improving in cardiac output. Dobutamine, it is mainly beta-1. Dobutamine is mainly beta-1 receptor, and it has a beta-2 effect for which it helps in improving cardiac output. And by activating beta-2, it will reduce SVR as we discussed in the previous slide. Epinephrine is a potent beta-1 agonist and also alpha-1 agonist. Epinephrine, you can divide it into low and high dose. So in low dose, it decreases systemic vascular resistance because it has some effect on beta-2. On high dose, it's mainly alpha-1 effect for which it will increase SVR. Dopamine, it is the medication of everything, I call it. So it acts on alpha-1, beta-1. It has no effect on beta-2, but it has a dopaminic receptor effect in some in organs. And again, it has a range of doses. We'll not go through them, but as I said, alpha, beta effects. So it will improve cardiac output and it will increase systemic vascular resistance. Now, based on the dose, which effect will be more, that will depend on the dose you have started. Then phenylephrine, it's mainly alpha-1 receptor. We use it less in ICU, but it is used more in anesthesia. And vasopressin, as we said, it is act on V1 receptor in the blood vessels, so it causes vasoconstriction. I know this slide is big, it has so many details and so many arrows up and down. I think we can simplify this by putting things together in this slide. So this slide, what is about this slide? So this slide, you have the medication, which usually we know or we have in our bedside practice. And we put on the right side the effect of that medicine on systemic vascular resistance. So here, that means the medication has a high systemic vascular resistance, or it leads to increase in systemic vascular resistance. And while you are going down, it causes decrease in systemic vascular resistance. On the other side, the medication would affect chronotropy and inotropy. So down, the medication which starts at the bottom, it will increase, or the main effect will be increase inotropy and chronotropy. And when you go up, there will be no or less effect on cardiac output. So let's start with those medications. As we said, phenylephrine and vasopressin act on purely on alpha-1 for phenylephrine. For vasopressin, it acts on V1. So it is mainly systemic vasoconstriction. So it increases systemic vascular resistance. So that's the main action of it, and has minimum or no effect. Let's say no effect on cardiac output because it has no effect on beta-1 receptors. Norepinephrine, it is mainly increasing systemic vascular resistance with some effect on cardiac output. Epinephrine, this is a medicine which has both effect with dopamine on systemic vascular resistance. So it increases systemic vascular resistance and it increases cardiac output by improving inotropy and chronotropy. When you go down further, for dobutamine and milrinone, it's mainly improving contractility and inotropy. So inotropy and chronotropy effect. And those two medications will lead to decrease in systemic vascular resistance, i.e. it will cause peripheral vasodilatation. So if you want a peripheral vasodilatation in constricted child, and you want a chronotropical effect and inotropical effect, then those two medication will be your target.
Thank you, Ahmed. Can we have only 9 minutes. Can we go through a clinical scenario and apply what you have said in those clinical scenarios so to make it more practical?
Good, excellent. So that's what we'll do next. So this slide will summarize what I have said already, and I will use it in your request. So if you have a child who has a shock and you want to start inotropes, there will be so many factors influence your decision. The main factor based on our discussion today should be the action or the effect which you want for these patients. It's either contractility, it's either inotropy, it's increasing systemic vascular resistance, and so on. So based on your understanding, you will put or you will choose your inotropes. And there are so many other factors like the availability of the drug, the cost, and your familiarity with the medicine and what access you have, because that will influence your decision. Let's take a scenario. And our first scenario will be the best to practice on. So the same child with ALL came with a picture of septic shock. With whatever you have understood from my presentation, I want a volunteer to tell me what best inotropes he will choose first after reading the scenario. Then I will show this slide so he can take me through why he chose the inotropes which he selected. So I want a volunteer to discuss with me. If I did not get a volunteer in 10 seconds, we will proceed. So we'll finish on time.
You can use also the chat to write what is the best or appropriate inotropic or vasopressor medication to start this patient on. So the patient is cold, has weak pulses, capillary refill time is long, and the patient have signs of low perfusion, confused, and very lethargic, and the patient is tachycardic. Abdul Hamid Al-Hanai said adrenaline. Also Ruwiya said epinephrine, which is the same.
Good, excellent. Now, the next question, why epinephrine? Based on whatever you have understood from the presentation, why epinephrine? In a child who is cold, weak pulses, almost relatively normal blood pressure. So that your decision is after the initial management with IV fluid and the other intervention. What is your target? What actions you want from these inotropes?
Dr. Ahmed.
Yes.
Resistance. So now we will add constants because we can cause vasoconstriction to non-vital organs.
Okay.
And can increase the blood pressure.
Okay. Okay, good. So just to make it simple, I will first of all go through some answers in the chat. So Khalid ATH said temperature 35. Excellent. Actually, that's a very nice and very excellent notice you have. If the child is hypothermic, so we are here, means afterload will be high. You need to rewarm this child to reduce the afterload so the heart will have less force to work against and will improve the cardiac output by reducing the afterload. So that's good. It's called shock. So adrenaline, right? Good. So cold shock means there is peripheral vasoconstriction. You have a child who's very tachycardic. He's very tachycardic and the blood pressure is relatively normal. So as we said in the previous slide that epinephrine in low dose will cause it has beta-2 effect, so it will cause peripheral vasodilatation, better perfusion because the flow will go better to the end organ. Mean arterial pressure, it may drop, but same time you are giving medication which improve contractility, and it will increase heart rate. So the cardiac output will be better, end organ perfusion will be better, and you will prevent tissue hypoxia, and you will support your patient. So yes, epinephrine will be a good choice in this patient. If no central line, Naji said use dopamine. Yes, you can use dopamine, but again, if you use low dose epinephrine till you get central line, you can use epinephrine too, up to 0.1 or 0.1 mic per kg per minute. Good, so I think we are running out of time. Another scenario, actually same patient, but now the clinical exam is a bit different. The child is warm, there's bounding pulses, Gabriel 2 seconds. The blood pressure now is different than before. And the child is hyperemic, temperature is 38. Systemic examination, bilateral lung crepitation, and you are lucky in your center, you have somebody can do a point of care ultrasound for the heart, and he noticed or she noticed there is the brisk cardiac function. Now in this scenario, do you want to choose or to pick another inotropes? Or what will be your choice for inotropes? So Ravia said norepinephrine. Dopamine is an answer. Noradrenaline. Okay. Okay, so the latest sepsis guidelines, it said there is no more warm and cold shock, because usually we refer to warm and cold based on our clinical examination. But with our clinical exam, we need to have some functional studies. And also you need to interpret your finding or your whatever information you have in terms of vital signs and the other information. In this scenario, you have BOCUS, which showed the brisk cardiac function. So if you have a child who is warm and the brisk cardiac function, it is not straightforward norepinephrine, because if you add norepinephrine, it will cause peripheral vasoconstriction. That means afterload will increase, means the heart need to bump against a resistance. So without giving any medication improving contractility, you may worsen the scenario. So in these conditions, you need to have a detailed thought and discussion what will be the best inotropes. So that's one factor. Two, warm and cold, it is dynamic in pediatric. You will find a child who is warm now till you prepare your medication, you will re-examine him. Or here you will find the child became cold, and whatever examination you have in 5 or 10 minutes, it has changed. But good, whatever decision you will take, it should be guided by your clinical judgment and understanding of the physiology of the disease. I think we reached the end of this presentation today. Last thing, I want you to practice what I have said to different type of shock and condition. Here are some examples. Remember the chart which I had explained to you, and I think it will be available to all of you if you ask for, as it will be one of our pediatric ICU card. So you can get it. And again, if you need the slides, I will be more than happy to share the slide with all of you. Thank you so much for your attention. And we are almost at 7:30. I will open the floor for any, maybe 1 or 2 questions, then we will close up. Meanwhile, till we get the questions, please scan the QR code and fill the feedback survey. Thank you.
Thank you, Ahmed. Someone asked what if I don't have it in my hospital? If you mean if you don't have adrenaline in your hospital, of course you can use dopamine. Probably dopamine will be more available. According to the new PALS guidelines, adrenaline is the first line to start. But if you don't have it or your team is not able or not familiar to prepare adrenaline, of course, definitely you can use dopamine.
Right, that's correct.
Also in patient who is someone said in the patient who was vasoconstricted to use epinephrine plus milrinone if BB is fine. I think that's also true. So if you have a vasoconstricted patient, very cold, but the blood pressure is okay, you can use milrinone to vasodilate. That will improve the perfusion. And also if you don't have milrinone, you can also use dobutamine as well. There is no evidence that milrinone is superior than dobutamine, so still you can use dobutamine.
Correct.
And some Naji, I think, asked why dopamine is not used frequently now. Ahmed, you have answer for that question?
Right, so you already mentioned that the latest sepsis guideline, sepsis campaign 2020, they eliminate or they took dopamine from the first line agent for septic shock. So either epinephrine or norepinephrine, even in pediatric population, based on your clinical judgment. That's one. Two, dopamine, the issue with dopamine, it is a rhythmogenic medication. So again, its use is very, very, very limited if you have a contraindication with other inotropes. So because of its side effects and because of the current evidence which promote use of epinephrine and norepinephrine, it is not, as you said, it is not used frequently because the evidence has changed.
Thank you very much. I think we will end here, and we wish to see you in the next session. We are planning to do one session per month. That will be also a critical care discussion, and we will meet other experts as well in the field. And each time we will talk about a different PICU topic. Have a good night.